Welcome. We're just going to give it a few minutes to let everybody get logged in here. Thanks for joining us today. I think we've had a few more people join us. We are just giving everybody a couple minutes to get logged in here. We'll give it just one more minute to get everybody logged in. All right. Well, thanks for joining us today. Welcome to Master Medicare with Margo. I am Kim Bazenbach, Director of Financial Planning here at FSA. As most of you know, we do financial planning and investment management. And there's times that we need to pull in or refer clients to other professionals to maybe go deeper into topics like taxes or estate planning, or in this case, Medicare. But before we bring in Margo, we wanted to quickly introduce you to the financial planners here at FSA. So I'm going to swap the screen so you can see all of our awesome advisors. And we wanted to introduce them just to say, while we do have Margo here to go deeper into the Medicare, all the advisors here can also talk to you about how Medicare fits into your bigger financial picture and cover topics like retirement planning, education planning, investment management, those types of things. And we actually met Margo because one of our advisors here on the call, Mike, heard her speak at a conference. And when he introduced Margo to the rest of the team, we were all just so impressed with her level of knowledge and professionalism that we felt comfortable having our clients work with her. So the one person you're not seeing on our screen that's part of the advisors is Dave Peterson. So some of you may know him. He wasn't able to join us today, but he is, of course, one of our financial planners as well. So we're going to say bye to the team for now. And one last thing before we bring in Margo is that just a housekeeping. We have a Q&A section at the bottom. Please feel free to throw in your questions along the way. Margo will probably answer some of them throughout the presentation, and anything she doesn't, she'll answer at the very end. And if there is something that's maybe a little bit more specific or unique to your situation, she may not be able to answer those during today's webinar, but that could be an opportunity for you to speak with her one-on-one. So without further ado, Margo, the floor is yours. Thanks for being here.
Thank you, Kim. I appreciate it. Let me go ahead and screen share here. And thank you all for joining on this awesome topic, Medicare. I often joke with my brothers and clients that I was born with a Medicare card in hand. Steinlage Insurance Agency is a family-owned and operated health insurance agency focusing in the Medicare product. We are 3 generations. So my grandfather started the company, and then my dad really focused our direction in the Medicare product in the 80s. And now myself and my 2 brothers are taking over the agency. So whether you're talking to me, you're talking to one of my family members, we are all able to assist in Medicare related questions. And it really is everything that we do in-house. So some of the services that our agency provides for clients that are nearing 65 or aging into Medicare, or now are coming off group coverage and needing Medicare well after their 65th birthday, we provide free advice for any of these scenarios. So how our agency works is we are independently owned and operated. We get appointed with all national health insurance carriers offering Medicare products in the majority of the states. And so when we sit down with the client, we really are giving a whole picture view of, do you need to pick Medicare at 65? What are the rules and red flags to watch out for upon turning 65 and needing Medicare? And then also we help you year after year once you do elect to go into Medicare. We are doing annual reviews and we are proactively reaching out to our clients each fall for that open enrollment once you're on Medicare. There were a few questions that were sent in prior to the webinar, and some of them relate around Medicare and working after 65 or having a younger spouse on the plan. That's also where we come in and really provide guidance on comparing group coverage. Are there children on the group plan and a younger spouse on the group plan, and now the older spouse is moving into Medicare? There's a lot of unique situations upon Medicare enrollment. There's no one size fits all piece of advice. So I will throw this out there. If you have specific questions that are very specific to your needs, do feel free to shoot me an email. You can CC your advisor on the email as well, so we're all in the loop. And I'm very happy to hop on a half hour or an hour call to further discuss your questions. But again, all of our services are free. Today is purely educational. So I hope you walk away with some new pieces of information that you weren't aware of prior to this webinar. Also, our agency is licensed in the majority of states. I believe we're at about 45 of the 50 states currently. So this slide's a little bit dated. Anytime we get a new client or a client moves out of the Virginia region, we follow them. So we really are getting referrals nationwide and can assist you regardless of where you are located. In this webinar, I want to focus on three main parts. First, we're going to walk through who is eligible for Medicare and what are the rules around working after or working and turning 65 and requiring to get Medicare or not being required to take Medicare. We're really going to dive in deep on who is eligible for Medicare. Then we're going to look at what is Medicare? What are these different moving parts? What is a supplement? What are the different types of supplements? What are the rules around changing those supplements? How does a drug plan Part D come into play? How does this compare to Medicare Advantage Part C? We're going to look at all of those moving parts and the lingo with those moving parts and really dissect that so you have a better understanding of Medicare and the ancillary products that come in to fill the gaps in Medicare. Then we're going to look at regulatory changes with IRMA, income adjustments, donut hole, coverage gap exposure for prescription drugs, and any new updates to regulations that are in the pipeline. So let's jump in. Before we jump in, I will say, feel free to interrupt me in the Q&A box. I know Kim mentioned that earlier, but do feel free to type out a question as you hear me talking about a specific portion of this webinar. Feel free to type out that question and I'm happy to stop and dive a little bit deeper with an answer. So who is eligible for Medicare? The general rule is that when you turn 65, you are required, or I don't want to say required, you'll be penalized if you are not signing up for Medicare at 65. So the general rule is that you need to sign up for Medicare upon turning 65 to avoid any penalties and late enrollment, penalties and gaps later on. If you are under 65 and you are eligible for Medicare due to disability and you're hitting your 24th month of disability, then you are automatically enrolled in Medicare Parts A and Part B, even though you're not turning 65. But for everybody else, if you're aging into Medicare at 64 or 65, the general rule is that you need to elect Medicare Parts A and Part B to avoid any late enrollment penalties and gaps in your coverage. The exception to that rule is if you are working or your spouse is working after 65, and through that active employment, your employer is offering you group coverage. The exception there is if you are working after 65 and you have access to group coverage, then the next question is, how large is that employer? Because the size of your active employer offering the group plan is the determining factor of whether or not Medicare is optional or required. So if you are working for a large employer or your spouse is working for a larger employer, which means 20 or more full or part-time employees, it doesn't matter. And it doesn't matter how many of those employees are actually enrolled in the group plan. What matters is the actual size of your employer, regardless of whether they're enrolled in the health insurance or not. So if your employer has more than 20 full or part-time employees, then Medicare Parts A and B are optional. You do not have to sign up for Medicare at 65. You can delay Parts A and or B and continue on that group coverage if your employer has 20 or more employees. So I like to say that a few different ways, but the size of the employer is the determining factor here. If it's large, 20 or more, then you can delay Medicare Parts A and Part B. You can stay on the group coverage. It will remain primary. You can keep that younger spouse on the plan. You can keep your children on the plan. And then when you're ready to retire and come off of that group plan, you create a special enrollment period that allows you to elect Medicare Part A and Part B and avoid any penalties or late enrollment consequences and gaps in your coverage. Another red flag to watch out for is if you have this large group coverage on the table and you're going to work after 65 and that large employer plan is competitive and you want to stay on it, you need to watch out to see if there's an HSA component built into the employer plan. An HSA, a health savings account. If you or your employer is contributing into an HSA, health savings account, then generally you need to avoid signing up for Parts A and B upon turning 65 if you want to continue contributing into the HSA. You can't have group employer coverage and contribute into your HSA and have Medicare A and B. You can't have both group with an HSA contribution and the free Medicare Part A or Part B component. Per IRS rules, you can't have both because they consider that double dipping. The HSA and the tax benefits that come with an HSA, health savings account, are negated when you sign up for this Part A hospital free benefit or Part B component because you no longer have a high deductible only plan. So you can't have both HSA and group and the Part A free hospital benefit. Another thing to watch out for is if you're in this scenario where I have large group coverage and I'm contributing into my HSA for the tax benefit, and now I'm ready to retire and drop the group and stop the HSA and move into Medicare Parts A and Part B because I'm 68 or 70 years old and I'm ready to retire. When you start your Medicare paperwork, your Medicare Part A will have a 6-month retroactive look back from the date you start your Medicare paperwork. So if you start in October because you know you want to retire at 70 in January, and you're starting your Medicare paperwork in October, you need to stop your HSA contribution 6 months prior to your October enrollment for that January 1st effective date. I know I'm getting really far in the weeds here, and only a few of you will like come across this issue, but I like to throw it out there because I see quite a few clients make this mistake working with their financial advisors or their accountants. This should be on your radar if you have an HSA built into your large employer group plan and you're going to continue working after 65. If your employer offering the group plan has fewer than 20 employees, then Medicare is required as the primary payer. So you need to sign up for Medicare Parts A and Part B upon turning 65, even if you have the group coverage, if that group or the employer offering the group has fewer than 20 employees. Per Medicare secondary payer rules, Medicare is required to be the primary payer when your employer has fewer than 20 employees. So if you delay Medicare at 65 because you say, hey, I have group, but it's a small group, and now you try to go to the hospital or see the doctor, your group's going to say, hey, you were required to pick up Medicare as primary. We're no longer the primary payer for your claims. You should have picked up Medicare. So you'll find yourself with a gap in your group coverage and a penalty on your Medicare coverage if and when you pick it up later. So to avoid any penalties and gaps, if you have a small group plan, you're a solo practitioner, you have 2 or 3 individuals on your plan or a family plan, you need to pick up Medicare Parts A and Part B to avoid the gaps and the penalties. If you are retiring before 65 and you have COBRA, and now you're turning 65, COBRA is not active group coverage. You need to elect Medicare Part A and Part B. If you do not elect Medicare Part A and Part B, generally COBRA stops when you turn 65, or you'll have a gap in your COBRA coverage because they require Medicare to be the primary payer. Any questions on the COBRA or HSAs or these working after 65 rules? So let me repeat that. The general rule is that you need to sign up for Medicare Part A and Part B upon turning 65 to avoid any penalties, unless you're working for a large group employer that's offering you group coverage through that employer. So if you have large group coverage with an employer of 20 or more employees, full or part-time, it doesn't matter, you can delay Medicare Part A and Part B. That's the exception. What I generally recommend is connecting with a broker or a Medicare resource about a year out from your Medicare effective date. If you're turning 65, put this on your radar at 64. Medicare and Social Security are very delayed with processing and answering phone calls. I have clients calling Social Security this month, trying to set up appointments. They're anywhere from 6 to 8 weeks out to get you in for an appointment or a phone call interview. So highly recommend just planning ahead for this so you know exactly what to expect. Don't wait until the last minute to talk and plan out your Medicare options. Also, if you are collecting Social Security and now you're turning 65, so if you're collecting Social Security prior to turning 65, then Medicare and Social Security are automatically enrolling you in Medicare Parts A and Part B for the first of your birth month. So if you're 64 and a half, you're already collecting Social Security, then Social Security is automatically enrolling you in Medicare Parts A and Part B, which will become effective on your 65th birth month, the first of the month. If you're not collecting Social Security, then this is a proactive approach. You have to opt into Medicare. So if you want to take Medicare at 65 because you have small group or Obamacare and ACA individual coverage, then you need to proactively sign up for Medicare Parts A and Part B, and you can start that process right at 3 months out from your birth month. And that's something our agency helps you with. We are setting everything up and giving you guidance whether or not you have to take Medicare at 65. If you do, we're going to walk you through the entire enrollment process. if you can delay because you have a competitive group, or you have a unique situation where you have a younger spouse or children on the plan, we are handling all of that at advice and future enrollment for you. Also, if you do have an HSA that you've contributed to over the last few years, HSA funds, once you turn 65, can really be used for any qualified medical expense. The only thing they are not able to be used on is a Medicare supplement premium, also known as Medigap. So if you want to use your accumulated HSA funds on dental, vision, co-pays on your prescriptions, deductibles, it's all fair game. The only thing that you can't use HSA contributions or HSA funds for is the Medicare supplement premiums. If you have IRMA income adjustments, you can use the funds for, you can use those HSA funds to pay for the IRMA income adjustments as well. So next part of the presentation, what is Medicare? So once you are ready to move into Medicare, whether you're turning 65 and you're required to take Medicare Part A and Part B, or you are now coming off your large employer group plan after 65, you're ready to pick up either Part A or Part B, what does that look like? So when you sign up for Part A and Part B, also known as Original Medicare, you have Part A hospital coverage and Part B medical coverage. Part A hospital, for most individuals, has a zero premium attached to it. If you or a spouse worked 40 quarters or more throughout your life, then you are able to receive this Part A hospital benefit at no cost. If your spouse, non-working spouse, doesn't have enough quarters, he or she can tap into the working spouse's work history and get this benefit for free, as long as the working spouse has more than 40 quarters or 10 years worth of work history. If you know off the get-go that, hey, I won't have enough quarters to get me the free benefit, then I would highly recommend starting your Medicare enrollment right at that 3-month opening to get in with Social Security and set an appointment. It will require an appointment or a phone interview with Medicare so that they can attach your working spouse's work history to your file. So Part A for most is free. Part B medical is going to have a standard Part B premium of $170.10. So Medicare Part B is income-based. That's called your income-related monthly adjusted amount, also known as IRMA. So most people will pay the $170.10 per month, and that's either drafted out of your Social Security check or it's being billed to you quarterly. Once you get your initial bill, you can set up easy pay, auto pay, monthly payments directly with Medicare. So most people are paying the standard Part B premium. This Part B premium for 2022 is $170.10. Next year, it's either going to go up a few dollars or down a few dollars. It just depends on what Medicare sets. We had a huge jump from 2021 at about $145 per month to 2022 at $170 per month. There's word on the street that will drop for 2023 because Medicare over anticipated its risk with this Alzheimer's medication possibly being picked up by Part B. It was not picked up by Part B, so we foresee this premium dropping by a few dollars for 2023. Now, if you are high income, if you as a single tax filer made over $91,000, or if you as a joint tax filer made over $182,000, then Medicare Part B premium will be adjusted and you'll see a higher premium. And that's where the IRMA comes in. We'll talk about IRMA at the end of this webinar, towards the end of the webinar. So Medicare, red, white, and blue card, you'll see Part A, Part B. With just original Medicare, no ancillary product, no supplement, no Medicare Advantage plan, no retiree plan. With just original Medicare as your primary payer, if you go into the doctor, you go into the hospital, you will have gaps in your coverage. If you go into the hospital, you're going to have a roughly $1,500 deductible per 60-day occurrence. So if you go in the hospital January 1st and then June 1st, you go in again, you're going to have a deductible reset. If you go in to see your doctor, you'll have a $233 medical deductible, and that's a per year deductible. You go in to see the doctor, you need outpatient knee surgery, you're paying the first $233, and then Medicare will cover roughly 80% of your medical costs. There's no ceiling or cap on your 20% coinsurance and exposure. So that's where all of these ancillary products come in. They come in to eliminate your deductibles and your coinsurance risk and provide you with drug coverage. So they come in to fill these gaps in Medicare. Once you're on Medicare, you really have two routes to choose from in selecting how you want to fill your gaps. Option one, you can take, which is on the left side of the screen here, you can take original Medicare, the red, white, and blue card, that will be your primary payer, plus you'll have a secondary supplement, also known as Medigap. If you go this direction, original Medicare plus your Medicare supplement, you'll need a standalone Part D drug plan. This combination will give you nationwide coverage and excellent coverage. I'll jump a little bit further into the pros and cons, but that's one option once you move into Medicare. Option two is you still pay Medicare, but you elect or you enroll in a Medicare Advantage Part C, HMO, or PPO styled plan. These are going to be your networked policies, which are a little bit more restrictive than what you see with option one, original Medicare and your supplement. It's important to note here that no matter which direction you go, once you move into Medicare, you are always paying that Part B premium plus any IRMA if it's attached to it. There's no way to avoid that Part B premium unless you're low income qualifying for Medicaid and state assistance. So let's dive a little bit deeper into Medicare and supplement and drug combinations. If you choose this combination, you will have nationwide coverage and Medicare is your primary payer. So when you walk into the hospital or you walk into the doctor and they say, show us your insurance, you're gonna, or who's your primary, you're gonna say original Medicare. You can go nationwide to any doctor that takes Medicare and you'll have close to 100% coverage for any Medicare approved charge. Medicare is your primary and your supplement, regardless of the supplement carrier, is mandated to pay as long as Medicare is being triggered as your primary payer. If you go in for cosmetic surgery and it's not medically necessary, Medicare will decline the charge. They'll deny it. They won't pay. Neither will your supplement. So the supplement will only pay when Medicare is charged and Medicare approves the charge. Your provider is required by law. If they take Medicare and opt into Medicare, they are required by law to bill Medicare for Medicare approved charges within a year of your claim. Generally, it happens within days, hours. They submit the claim to Medicare. Medicare turns around and pays its portion and sends the residual claim, the leftover billing, to your supplement on file. Your supplement is mandated by law to pay when Medicare pays. So your supplement, whether you go with United Healthcare, Care First, Anthem, Humana, Cigna, Mutual, I mean, there's plenty of carriers out there. They are all required to pay once Medicare is triggered. So you would never ask, and under this type of insurance, you would never ask, do you take my supplement carrier? If you start asking these questions, your doctor's office is really going to get confused because they're going to think you have a Medicare Advantage plan, which is networked. So when you have original Medicare, you always ask, do you take a Medicare? Do you take Medicare? Is this Medicare approved? The supplements, you have Plan F, Plan G, Plan N. Those are some of the most popular supplement options. Plan F was very popular over the last decade. As of January 1st of 2020, anyone new to Medicare after January 1st of 2020, anyone new to Medicare cannot sign up for a Plan F supplement. Plan F covered 100% of the gaps in Medicare. So it covered the Part A hospital deductible, that's $1,556 per 60-day occurrence deductible. Plan F covered it. Plan F covered the $233 annual deductible and the 20% residual. So you showed Medicare, or you showed your provider Medicare card and Plan F supplement, you had 100% coverage. As of 2020, no plan after 2020 can cover 100% of the gaps in Medicare. So Plan G, as in girl, came on the market and said, okay, we won't cover 100%, but we're going to cover pretty darn close to 100%. So Plan G is currently the most popular option. Plan G, girl, supplement, covers 100% of the gaps in Medicare, except for that Part B medical deductible. So you have original Medicare card and your supplement Plan G card, doesn't matter who the carrier is, your supplement G will cover all of those gaps except for the $233 deductible. Once you satisfy that deductible, then Medicare and your supplement G covers 100% of Medicare approved charges. Plan N is in Nancy, is one step down in benefit. Plan N will cover 100% of your gaps except for the $233 per year medical deductible. And you'll have a $20 provider copay and a $50 ER copay. The biggest gap in Plan N is that if you go to a Medicare doctor, that doctor always has the option to accept Medicare assignment or opt out of assignment. So they could take Medicare and see Medicare patients, but they have the ability to opt in or out of Medicare assignment. And what that means is the doctor can either opt into Medicare assignment, meaning they agree to Medicare's reimbursement rates and will charge per Medicare's reimbursement rates. Or that doctor, if they opt out of Medicare assignment, they can charge up to 15% higher or balance bill the patient 15% higher than what Medicare approves. So if Medicare approves a primary care visit at $100, that doctor that's non-assigned can charge 15% or $15 higher, and you're responsible for that with a Plan N. That's called a Part B excess charge. Your Plan N does not cover Part B excess charges, whereas F and G does. So we're really far in the weeds here, but I get a lot of questions on F, N, and G and the differences. Those are the only differences between those three plans, aside from premiums. In addition to getting a Medicare supplement plan, you will also need a standalone drug plan to cover prescriptions. Part D is optional. However, if you decline drug coverage when you first become eligible for Medicare and you go 3 or 10 years without drug coverage, when you are ready to elect a drug plan, you will get hit with a late enrollment penalty. I'm sorry, late enrollment penalty. So it is optional with the warning that, hey, you're going to get penalized if you don't pick it up when you first turn 65 or first become eligible for Medicare. So what I always tell most clients is that if you are turning 65 or you're aging into Medicare or coming off the group coverage, and you're ready for Medicare and you're not on prescriptions, get the cheapest drug plan that's out there, just so $7, $10 a month, so that you can protect yourself from this late enrollment penalty, and you have protection with drug coverage if and when you need the one-off medication. Drug plans range anywhere from $7 to $100. What we do for all of our clients is we review your medications to find the best plan based on total cost. Total cost meaning premiums, deductibles, copays, annualized for the year. Who out of the 30 different drug plans out there, who's giving you the most bang for your buck year after year? We are proactively reaching out to our clients every September, asking for updated prescription lists so that come October and November, we can review all of our clients' drug plans to make sure they are in the best plan for 2023 and beyond. So it's a proactive approach that we offer for each of our clients. If you are currently 65, you're on Medicare, your broker should be doing this for you for free. It's a lot of legwork, but I would say about 25% of my clients need to make a change based on their drug plan updates, their prescription updates, and we're saving anywhere from $600 to $2,000 on medication costs. There's a ton of volatility in the drug plan market. Highly, highly, highly recommend making sure this gets reviewed every year. If you wanted to add dental and vision, this would be a separate policy, a separate component that you would add to Medicare supplement and drug. And those are generally ranging about $40 a month. There's some bare bone policies at about $30, but most are in the like $40 to $50, $40 to $60 price point. Any questions on the supplemental? Okay, hold on. We do have one question. I'm not able to pull up the Q&A here. I'm not sure what's going on.
Margo, I have it.
Okay, thanks, Kim. Can you read that for me?
Yeah, the question is, are there plans that cover medical charges rejected by Medicare and Medigap?
No, there's no ancillary product that you can pick up that would cover a non-Medicare approved charge. If you had a group plan and Medicare was the primary and you were on a old like retiree option, they may pick up the claim, but most of the time, once you're on Medicare as the primary, because you're on small group or you are like required to take Medicare at 65, Medicare is kind of the dictator here. If it's not picking up the claim, there's no ancillary product that you can pick up. Like federal, I don't think anyone on here is a federal employee. Federal employee health benefits may come in and pay a secondary, but generally if Medicare is declining the coverage, you're out of pocket, unfortunately. But I will say Medicare's, outside of the drug plans, Medicare with their medical and hospital coverage is very liberal. I don't get too many complaints on or like negative feedback from clients on medical and hospital claims being denied. Where I see the most issues arise, it's in the Part D world, the prescription drugs. And we'll talk about some of the future congressional bills that may be passed here in the next year or two, fingers crossed, for capping Part D exposure. But that's where I see the most problems arise. Also, if you have, I will just throw this out. I don't want to go to the next slide. This is not pertaining to this slide, but if you have Obamacare or individual ACA coverage and you are receiving a subsidy for it, and now you are turning 65, the government doesn't mandate that you have to pick up Medicare A and B. You can stay on your Obamacare plan, but two things will happen. First, your subsidy will be removed. So if you were getting really cheap insurance through ACA because you were able to manipulate your income or you had a low income, once you turn 65, you will end up paying the full premium on that ACA Obamacare plan. So you'll go from $300 a month to $1,300 because the subsidy is fully removed. And if you don't elect Medicare, that penalty will begin the day you become eligible at 65. So not only are you going to pay more for your ACA individual coverage because the subsidy is removed, you're also starting a clock for the Part B late enrollment penalty. So not sure if anybody on here has a individual plan and they're getting subsidy. I'm throwing that out there because I do get that question often from clients calling in about their ACA coverage. Okay, so option one was Medicare, original Medicare with the supplemental and the drug. That's kind of the Cadillac coverage, the most flexible coverage. You know what to anticipate cost-wise each month because your premium, and you know what to anticipate cost-wise on the back end because you have excellent coverage. The alternative is original Medicare with Part C Medicare Advantage. If you go this direction, again, you will still pay Medicare, the Part B premium plus any IRMA. But as soon as you elect a Medicare Advantage Part C HMO or PPO plan, Medicare is no longer your primary payer. So you put that red, white, and blue card in your pocket in a safe spot and you never show it. You are now showing only your Medicare Advantage HMO or PPO card for all care rendered. If you go into the hospital, if you go into the doctor, if you go into your dentist, if you go into the pharmacy, you're showing that Medicare Part C HMO or PPO Advantage card for all services rendered. This is where you have to start asking, do you take United Healthcare? Do you take Humana? Do you take Blue Cross? Do you take Aetna? You need to make sure that your doctor is in network to get the most bang for your buck out of this plan. If you have an HMO Medicare Advantage plan and you want cancer treatment at Mayo Clinic, you are out of network. You are 100% on the hook for that cancer treatment. The HMO requires in-network use only unless it's an emergency or urgent care setting. If you want kind of the hybrid, the PPO will allow you to go nationwide to any doctor that takes Medicare, but incentivizes you with the best in-network rates for in-network doctors. If you go out of network, you're usually paying a higher copay or a flat co-insurance rate for that out-of-network access. The PPO does allow more flexibility, but there's more out-of-pocket risk if you go with that PPO and use out-of-network care, whether it's an emergency or cancer treatment or surgery, and it's out-of-network. You'll just pay more. With these Medicare Advantage plans, most, depending on where you live, if you're Maryland really doesn't have very competitive Medicare Advantage product yet. Virginia's fairly competitive. You have a lot of zero premium or low premium Advantage plans. However, on the back end, when you start utilizing care and you have these co-insurances or these co-pays, you are paying select negotiated co-pays and co-insurances up to your plan's max out of pocket, which in Virginia, those range about $4,000 to $11,000 per person per year. And that resets on January 1st. So it is low premium and it looks really attractive with free dental, free hearing, free gym, free vision. Joe Namath really looks attractive on TV. But the backside is that if and when you start using care, you really have high out-of-pocket exposure if you have a bad year. And you tend to see a lot of prior authorizations with these types of plans because at the core, these advantage plans are trying to maintain profit. They are receiving a subsidy from Medicare. You pay Medicare your Part B premium. Medicare turns around and pays the Advantage plan a subsidy each month to insure you. Medicare Advantage is trying to maximize their profit off of that subsidy by managing your care, creating networks to manage their cost containment, prior authorizations, restrictions. So there tends to be more headaches with these Medicare Advantage plans. But if you are the type of client that wants to take on risk, you have a large appetite for risk, you are incentivized by the cost, then these Advantage plans are attractive. I have many clients in Advantage and many clients in Supplement. My goal is to create transparency to help you decide which direction is right for you now and also for the long haul. Because your decision when you turn 65 or when you are coming off large group and you're ready to move into Medicare, your initial decision of going Medicare Supplement or Advantage can have long-term consequences. And we'll talk about that here in a second, but we do have another question. So Kim, if you can pop back on and read that for me.
Yeah, Margo, I think you actually just answered it.
Okay.
The question was, if you choose Part C, can you ever switch back? And it sounded like
okay,
you were
that
kind of
leads
going
me
there.
to my next slide.
Perfect.
Great questions, guys. So caveat, if you choose Medicare Part C because you're healthy at 65 or you're healthy when you're coming off your group, that's great. But now 5 years later, when you're hitting your Part C's max out of pocket of 5,000 or 10,000, you call me and you say, Margo, I really want to move to the supplement. I'm ready. I need the better coverage. Now you have to answer health questions and go through medical underwriting. To drop your Part C, you have to get approved by your Medicare Supplement Medigap plan, because now you're outside of your 65th birthday or special enrollment window. You're coming off group, you're outside of those windows. You have to drop your supplement or Advantage plan, Part C, and get approved and go through medical underwriting with your supplement. And the supplement, also known as Medigap, those plans can still deny you coverage because of poor health. They can outright deny you, leaving you in this Medicare supplement world. If you choose Medicare Supplement off the get-go, 45 of the 50 states, Virginia, Maryland, and also DC, all require underwriting to change carriers. So if you're going in supplement, you really are selecting the supplement for the long haul. You can go supplement G to supplement G, supplement G to supplement N, carrier to carrier or internally, but you always are required to answer medical underwriting in 45 of the 50 states. Where I'm originally from, Missouri, we have a unique law that allows you to shop your plan on your supplement plan's anniversary. Missouri, Oregon, Illinois, New York, that's 4. I know there's one more out there. Will allow for special kind of unique anniversary period or birthday rules for your supplement plans. But all other states, if you're in Virginia and you choose United Healthcare or Mutual of Omaha off the get-go for your supplement G, and 5 years later, you want to go to Aetna G, you have to answer health questions. Or 5 years later, you want to go United Healthcare G to United Healthcare N, you need to answer health questions. If you want to drop your supplement and go to a Medicare Advantage plan because you're sick of paying premiums and you don't see value in the supplement anymore, which I rarely see, if you want to go that direction, then you would drop your supplement during the annual enrollment period, which runs October 15th through December 7th, and you would enroll in a Medicare Advantage plan with no health questions for a January 1st effective date. But you can't drop your Advantage plan and move to a supplement unless the supplement will approve you and you can pass medical underwriting. If you choose option 1 here, original Medicare with a supplement and a standalone drug plan, it's difficult to shop your supplement if you become unhealthy. So you're kind of left in that supplement carrier. So what we are doing, we are trying to fit you with qualified, large market known entities so that your supplement has a good chance of survival and rate stability for the long haul. Is your supplement community rated? Are they attained age rated? Are they issue age rated? What's their market share? Do they have 1% market share? Do they have 40% market share? What's their risk? Do they have large claim payouts? All factors that these companies use to adjust their rates year after year. Your Part D drug plan, we can review every annual enrollment period in the fall, and we can move you drug plan to drug plan very easily without any underwriting. So that's where we come in proactively and ask for drug list to make sure you're always in the best plan based on current medications. You can't change drug plans mid-year, but your drug plan has built-in protections for the consumer. All drug plans, I believe it's 6 therapeutic categories that they have to provide drugs in, and there's usually 2 generic and 1 brand. If your drug plan does not have your specific medication that you're prescribed mid-year on its formulary, there are appeal processes that you and your doctor can take to request an exception and add your medication to the formulary. I wouldn't say that happens often, but I get a handful of those emails from clients saying, hey, what's the step for the formulary exception appeal? But the drug plans we can change very easily. So again, caveat, there are consequences to the direction that you choose, whether it's supplement or Advantage. So again, I'm going to lay out the review periods. So I'm coming up for my current clients. This is what I've been working on this week, is generating our email campaign to ask for our encrypted review form to be completed by all of our current clients so that we can begin our review process right off the get-go come October 1st when new plans are released. October 15th is when we can actually start recommending changes. That's the annual enrollment period. We can shop drug plans, or we can move Advantage plan to Advantage plan. No health questions to make those moves. The open enrollment period will run from January 1st to March 31st. That's a good review period. If you had a supplement and somehow got swindled into signing up for a Medicare Advantage plan, you can make a one-time move back to your supplement carrier if it was your first time in the Medicare Advantage plan, or if you were in the Medicare Advantage plan to start and somebody said, hey, sign up for this new HMO. It has all your doctors and covers all of your meds. Sign here, and you sign there. And February 15th comes around and lo and behold, your plan does not cover your doctors. You can make a one-time move from Advantage to Advantage during this open enrollment period. You can also move from your Advantage plan back to original Medicare with a Part D plan, but the supplement component has to be medically underwritten. So you could find yourself with large gaps in coverage if you're not able to pass the supplements underwriting. Also, Medicare supplements, you can always rate shop the supplement anytime throughout the year, but you have to answer health questions. So if you are turning 65 this year, you set up a Cigna supplement, and 4 years later, you call me in February and you say, or April or August, and you say, Margo, my supplement went up 8% this year. Are there any alternatives? I can say, yeah, sure, let's look, let's take a peek at your rates. If there's something more competitive, regardless of the time of the year, we can always request to make a move, but you have to be medically underwritten to make the move to the new supplement carrier. Okay. So I feel like I go really deep into these Medicare conversations. So I am apologizing if I'm making you more confused. I'm hoping this is clarifying some, but I realize for some of you, this may be brand new material, and insurance is a foreign language. So I know the team here is recording this. It's going to be up on their website. I have it also on my website. So just know that you'll be able to access this webinar and ask myself or your financial advisors any questions down the road. I know we're covering a lot of territory here. So the last part of this webinar is IRMA and income income changes. So Medicare's unique. They are looking at your modified adjusted gross income that you filed with the IRS 2 years ago to set your current year premiums. So perfect example, if you are turning 65 in 2023, you sign up for Medicare, Medicare is going to look at your 2021, your 2 years delayed, 2021 modified adjusted gross income on file to set your 2023 premiums. If you filed jointly, they're looking at your joint modified adjusted gross income. If you filed as a single tax filer, they're looking at your single tax modified adjusted gross income. If you, as a joint tax filing couple, made over 182,000, then you are going to see this first bracket IRMA be added to your premiums. So if you made between 182,000 and 228,000, then you're going to pay an additional $68 on your Medicare Part B surcharge and $12.40 on your Part D surcharge. If you made under 182,000, then you are paying just the standard $170.10 Part B premium with no IRMA. 91,000 and above is the income benchmark for single tax filers. Note that if you're married but filing separately, your income brackets are wildly different. There's really no way to avoid IRMA if you're above 91,000. So you can see here when I'm doing a review with a client, you're turning 65, you're 6 months out from your 65th birthday, you plan to work well after 65. Everything you read online is telling you sign up for Medicare, you're going to be penalized. The first thing I'm looking at is, the first few things I'm looking at is what's the size of your employer? Do we have to take Medicare at 65? If no, then let's look to see if Medicare is more attractive, more competitive than your group coverage, because not all group plans are competitive. Are there any spouses or children on your group coverage that come into play and are factored into this equation? Is your income high? Will it continue to be high because you plan to work? Maybe Medicare doesn't make sense because you're making $750,000 and Medicare is going to run you close to $600 a month in IRMA premiums. So we really are looking at the whole picture. When we request information from our clients, we're a little invasive. We are asking for your AGI from the last 2 years, current year, and future AGI. Is there retirement? What are your medications? What's your health history? We really are getting in the weeds, and we need this information to give you accurate, informed information. because not everybody has to take Medicare and not everybody's just going to pay the $170 per month. There's many factors that come into play to throw wrenches into your retirement planning here. Also, if you have a home sale and it creates a capital gain, if you have a required distribution at 72 or beyond, those are all things that can affect your income and 2 years later create this high Medicare premium with IRMA. So this is where I like to connect back with my financial advisor to say, hey, let's keep our eyes on our income, because it can have some consequence on what I pay for Medicare down the road. Now, we can appeal IRMA under certain life events. So let's say in 2023, you are turning 65, but you decide to retire, or you are now 70 and you're ready to retire and come off your spouse's large group plan. Medicare has no idea that you're retiring and that your income is likely dropping because of retirement. They're still going to have your 2-year prior tax information on hand, which was high because you were working. So if that's the case, we will do an IRMA appeal. If 2 years ago you were making $400,000 and now you're retiring and you're living off of cash and Social Security, we can remove all your IRMA or at least reduce it substantially. The most common life events that allow for a appeal or reduction in your IRMA is divorce, work stoppage, or work reduction. If you have a home sale and it triggers a capital gain, high adjusted gross, no way to appeal the IRMA in that scenario. If you have a high distribution or dividend, no way to appeal there. Also, if you are planning to retire and your company offers you a $1 million payout versus a $400,000 3-year payout, how does that affect your IRMA over 1 year versus 3 years of having high IRMA? Because you can't appeal the high IRMA because you're getting paid by this either lump sum or 3-year, 5-year payout. All things that come into play. And again, this is where I really like to bring in the financial advisors so that we can get a good idea as to anticipated modified adjusted gross income. Any questions on IRMA? Also, IRMA, generally Medicare is sending out, once you're on Medicare, Medicare is sending out IRMA determination letters about 1 to 3 months after you enroll in Medicare, and they're updating their information every 2 years, or I'm sorry, every year in November with your prior 2-year tax return. So if you sign up in 2022 for Medicare, Medicare is going to turn around and reevaluate your income for 2023 based on your 2021 AGI. In 2024, they're going to update based on your 2022 AGI. So you may need to appeal twice if you have back-to-back high 2020 and 2021 modified adjusted gross incomes on file. It's a pretty easy appeal process, and we work with our clients to get that done. I recommend starting the appeal as soon as you get your IRMA determination letter in the mail, because it's anywhere from 60 days to 120 days for them to process and reduce and remove IRMA. Always pay your IRMA until it's been reduced or removed. Then you'll have a credit or an overpayment for the overpayment of IRMA that you made, and that credit will be put towards future Part B premiums and lower IRMAs if you are still paying IRMA, but in a different bracket. Okay, I'm sick of saying IRMA, so I'm going to go to the donut hole and coverage gap. But if you have questions on the income-related monthly adjusted amount, and it's pretty specific, feel free to shoot me an email. I'm happy to answer your questions. Or you can send a question on the Q&A. if it's not too specific to your situation. So donut hole exposure, also known as coverage gap. So as of current date, the donut hole is closed. What that means is it's capped at 25%. And I'm going to go to the next slide because I think it's helpful to see a visual of a donut. So right now with Medicare regulations and laws, if you go Medicare and you don't have a federal employee health benefit plan because you're a non-federal employee, you don't have a retiree option that's competitive, there's no way to avoid the donut hole at current date. It's kind of like the question where we had earlier, where if Medicare doesn't approve the charge, can I have an ancillary product to protect me? No, there's no ancillary product to protect you for this coverage gap donut hole, because all Part D, whether you're getting it through Medicare supplement and Part D standalone, or your Part D is built into your Medicare Advantage plan, all of the Part D products, regardless of how you're getting it, will have identical like stages in Medicare. So the first stage is the deductible. Let's say January 1st, you move into Medicare, you have your supplement drug or Medicare Advantage plan set, and you are filling a $1,000 Eliquis. You go fill Eliquis at a $1,000 retail cost at CVS the 1st of January. You're going to pay the deductible, whether it's $200 or $480. You're going to pay that full retail cost until you've satisfied the deductible. Then you will move into the initial coverage phase, where you will pay copay on that Eliquis $1,000 medication. So under this graph, you would pay the first $480 out of pocket. Then you're bumped into the initial copay stage, where you're paying $42 for the Eliquis each time you fill it. For the next few months, you go into CVS and you're paying $42. Things are great. What Medicare is calculating on the background, regardless of the plan you're choosing, Medicare is calculating your retail cost of all meds being filled throughout the year. So if you're filling Eliquis each month, that's a $1,000 retail cost med. Medicare's calculating that on the back end. By month 4 and 5, you've hit the initial coverage phase threshold of roughly $4,400. Now, instead of paying a simple copay on Eliquis, you're dumped into stage 3 coverage gap, also known as the donut hole. And now, instead of paying that simple copay of $42, you're paying 25% of the cost of brand name drugs and 25% co-insurance on generics. So $1,000 retail, 25%, you go up to paying $250. That's the donut hole. That's the exposure. If you're on a $10,000 retail cost med, 25% co-insurance, $100,000 med, 25% co-insurance. Huge gap in Medicare. Tons of proposals that have come and gone. Right now in the White House, it's the Build Back Better Act that Biden's proposed. If it passes, it will cap all Medicare beneficiaries, regardless of how you're getting your drug coverage, at $2,000. So there will be no donut hole. You are capped at a maximum of $2,000. Right now, you would pay 25% co-insurance until you're true out of pocket. What you pay in the deductible phase, what you've paid in initial copays, the $42, what you've paid in the 25% co-insurance, when all of those come together to meet the $7,000 coverage gap threshold, you now exit the donut hole or coverage gap phase, and your exposure drops to 5% co-insurance. 5% co-insurance on a $10,000 medication is still extremely expensive. So there's no way to eliminate this exposure here. We are hopeful that an act will be passed, a bill will be passed here in the near future. This is the closest I feel in the last 10 years we've come to some type of workable law that really caps this exposure in Medicare Part D. So stay tuned there. Right now, nothing's passed. This is what we are working with. But if you are watching this and you're 59, 60, 63, there's hope for the future with Medicare Part D. So stay tuned. I know it's high on my radar, and I'll be working with clients every open enrollment and kind of keeping everybody in the loop with these regulatory changes if and when they get passed. Also, there was some regulation passed. I'm going to go back a slide. Last year, we had huge regulation passed. I sound like Trump. Huge, huge regulation passed with the insulin savings program. So over half of the drug plans, whether you're getting them with Part D or Medicare Advantage, insulin is usually capped at a $35 copay in all of these stages of Medicare. So this is a great win because in the past, pre-2021, Medicare beneficiaries, if they were diabetic trying to fill insulin, were paying anywhere from $200 to $300 in this coverage gap donut hole for their expensive insulins. So now everybody's capped at a $35 copay in all of these stages, which is a wonderful thing. We're seeing a lot of clients save quite a bit of money. So what to take away? A lot of different moving parts, especially if you're working or you have younger spouse or children on the plan. If you're retiring early, also unique situations. There's no one size fits all. Highly recommend speaking with somebody who can walk you through kind of timelines and recommendations, not just the standard, oh, you got to sign up for Medicare, take the Medicare Advantage plan. Not the case. Many different factors to consider and red flags to avoid when you're walking through this Medicare process and you're nearing the age of 65. So if you guys have any questions, do feel free to shoot me an email. I am happy to answer anything that you guys throw at me. I've been doing this for well over 10 years, and I plan to do it for the next 30, 40 years. So hopefully my kids can take over the business if they want to. But do feel free to reach out. And if there's any questions, do the Q&A box. I'm going to read some of the questions that you guys sent Kim prior. So one of the questions that I found interesting, so long-term care is not covered by Medicare. So let's say you're in a skilled nursing facility for over 100 days, Medicare will only cover 100 days of skilled nursing care. Anything over that, assisted living, home health, that's all going to be a separate type of policy called long-term care or estate planning. I mean, there's hybrid life insurance and long-term care policies that are out there that are very unique and interesting. So I'm just know that long-term care is not part of this equation here. There was one question, how do I deal with Medicare and spousal coverage when one spouse is retired and 60 years old? If you're on here, shoot me an email. If that was your question, shoot me an email. I need more information to answer that. Okay, we covered the ACA exchange plan until 65, then you move off the exchange, Obamacare, and into Medicare at 65. Can you be covered by both a Medicare supplement plan and a company plan at the same time, assuming the company plan goes first? Yes. So let's say you are on large group coverage. In that scenario, Medicare or your group is the primary payer because you're on large group coverage. And then Medicare becomes optional. So if you select Medicare Part A and Part B, which I wouldn't recommend, you would have kind of dual coverage. Or group is primary, and then your Medicare A and B is secondary. You don't need the B component. You're just overpaying for coverage. You would delay B and potentially delay A if you have an HSA until you're ready to come off the group coverage. If it's small group, under 20 employees, and you have Medicare because you're required to take Medicare, then the question becomes, do you need to keep the small group as a secondary? Why do you need to keep the small group as a secondary? Do you have a younger spouse on the plan? Do you have children on the plan? Do you have expensive medications? Would it make more sense to drop the group as secondary because it's small and move to a supplement or drug plan, or stay on the group as secondary because of these additional factors with family and spouse on the plan, or high income? So all factors that I consider when I'm doing my review with you all. I think everything else we covered. If again, shoot me an email if there's any questions that you guys come up with. I'm happy to answer. I'm gonna stop my screen share and put myself on in the background, but we will be around for the next few minutes. If you think of something, just type it out in the Q&A box.
Thanks so much, Margo. This was great information. And we will, when we end this webinar, there will be a web browser that pops up for everyone, and that'll have a link to our survey. If you guys wouldn't mind just taking a few minutes to give us some feedback, we'd love to hear from you on what you liked, what other questions you may have. And if you don't have Margo's information, there is a spot on the survey where you can put your name and email so that she can reach out to you if you have additional questions. And then also we will be sending, if there's anyone that you think could benefit from hearing this this webinar, we'll actually have a recording of it, and we'll email out a link to that. So you feel free to share it with your friends. It'll also be on our website. And then lastly, just thanks again to Margo, and thanks to all of you for attending.